Always, oh, I should mention this. Thanks. Because there's so many people, we're gonna keep people muted, and if you have questions, just please feel free to add your thoughts or questions in the chat. If we don't get to them today, we will get back to you as best we can. Always be comfortable reaching out to myself or Kelly, and we can connect you with Charles or get answers to your questions. So we're excited about today's discussion, and hopeful that it'll add some excellent skills to your toolkit. Thank you for being here.
Oh, Charles, I think your phone is muted.
Okay, can everyone hear me?
Yes, we can hear you now.
Okay, good. Okay, I got my little earphones in, and now people can hear me. Thank you very much for this opportunity to share some of my work and what I find very helpful for individuals to help colleagues and coworkers and families and patients settle themselves down so we can have a better and safer experience. The title of this lecture is Skills to Calm and De-Escalate Emotionally Dysregulated Patients. So it's get that person who's activated and angry, whatever, down to a level where they can communicate, and then you can get to the yes part of your interaction. And this is based on science. It's based on a modern attachment theory, which is a combination of the neuroscience of development, which affects behavior, and object relations, which is essentially a theoretical perspective where we have mental models in our head that we project on other people and things, and then we react to the mental model instead of that person in front of us. Please.
I'm getting questions that that we can't hear you well. Can you turn your speaker up, Charles? And also, folks, I'm going to mention that if you go to where it says mute, to the right of that, there's a little caret. You can go into your settings and turn up your speakers, which will also help. So.
Okay, go. This is on my phone now.
Yeah, turn your speaker up on your phone for you, Charles. What I said to other people was more for.
Okay, how is this? Any better?
Yes, much better. Much better.
Okay, good. Okay,
thanks,
very good.
Guys.
Okay, very good. All right, so basically we're going to talk a little bit about developmental and environmental influences that shape behavior. I find that if you can understand the why, you can better shape another person's behavior. So if you can understand where they're coming from historically, as well as what's in front of you, you get better results. We're going to definitely spend time talking about emotional self-regulation and how to use this to co-regulate the upset person. This is how we are designed as human beings. We'll talk a little bit about designing scripting and other kind of staff-developed interventions to manage particular developed people or families. And then again, of course, understand what it means to be an adult. Being an adult means being in charge of your emotions. And what I see in these heated situations is when somebody gets threatening, everybody regresses and loses sight of the present situation. Okay, next frame, please. All right. Okay, a little bit of a literature review. Apparently, workplace violence has been extensively studied in hospitals, but there has not been a lot of research done on the outpatient visit kind of places, clinics and such. So between 2000 and 2019, there were 13 quantitative and 5 qualitative research studies published, which focused on the family patient perpetrated violence. Please. Okay. So you can see, depending upon the clinic, violence ranged from 9.5% to almost 75%. Most common form of violence we will call verbal abuse, followed by threat of assault, bullying, physical assault, and sexual harassment at the small end. So it's obviously quite a pervasive problem. And one thing that all the literature showed is that most workers did not receive any training on how to manage the violent patient. And noting that most of the violence is verbal, they haven't had any education on that. And that's what this talk is about. All right. All of us experience the trauma of normal development, and some experience worse. So we have experiencing trauma when you're growing up from the time you're born is like having an immune system. You have to be exposed to germs to develop an immune system, and you also have to experience some age-appropriate trauma to develop that resilience. Pretty much everyone can recall the first day they went off to school, kindergarten or whatever. That was not everyone's best day. It was traumatic, but you learned how to cope with it. So when you cope with these life traumas and interactions with people, you develop a fair amount of resilience. Some people get a lot of experiences and a lot of resilience, some people less, and some people have horrendous traumatic things happen to them, and then that turns into difficult behaviors. Ultimately, I find in the general population, there's a general failure to effectively communicate. We have wonderful technology for passing information, but the communication part is degrading over time. And when somebody's having an emotional crisis, it's a very, very complex situation, and we have to help people come down to where they can think and reason. All right. This frame here basically just talks about aggression. We are humans, we are primates. Aggression has many, many reasons, generally speaking. We get aggressive when we feel threatened or when we want something. And you can see this play out from low grade with words all the way up to warfare on a large scale. Violent aggression can be either turned off or on, inhibited or otherwise modified. And the prevailing socio-cultural milieu, the culture you live in, plays heavily into this. If you grow up in a culture or a subculture here in America where you have to be aggressive in order to survive, you will be aggressive, and apply that to most venues, including walking into a clinic or a hospital, what have you. It doesn't really work in the new venue because we operate off of different rules for aggression. Next frame, please. Right. So aggression is not a single behavioral category, so it's not an easy fix. We learn how to be aggressive from our parents, and once we leave home, our peer group is the most important for learning behaviors, aggressive behaviors, and pro-social behaviors.
I actually, you know the one I got.
Kelly, I think either Charles is muted or we lost him.
I think he unmute. I just asked him to unmute. I think his phone inadvertently muted.
Oh, okay.
Figuring out, can you hear me?
Hello.
Hi, Charles.
Awesome.
I
We'll never
unfortunately
say.
lost the screen. Oh, here are the screens coming up. Sorry, everyone. All right. Okay. So there's a lot of social social reasons for learning various levels of aggression. Next frame, please. Okay, there's a lot of influences that may cause us to be aggressive. Actually, our genetic history and our social history that can go back many, many decades is an influence. Our childhood experiences when our brain was being assembled, like when our neurons were getting myelinated, our socialization through life, physical or emotional pain or frustration increases the capacity for aggression. And we find that displacing aggression onto someone else helps us feel better if we're predisposed to aggression. So in other words, if it works and it feels better, people will continue to do it. And one thing I always suggest people to do when they're dealing with somebody who has a problem with aggression, or anyone for that matter, is to ask or try to find out what happened today, what happened yesterday, and perhaps what happened the day before, because the behaviors over the last two days or so will give you a good indication of what might happen later on today.
We're not hearing you, Charles.
Okay.
Now I am.
Okay. Yeah. The internet keeps cutting on and off with the screen.
If you want, you could pull up the presentation in your own PowerPoint and just look at it from there and just tell Kelly when to go. Right now, we're on dominance and aggression. No, we're on dominance.
Okay. All right. In regards to dominance, we all have a dominance hierarchy, and somebody always wants to be at the top of the hierarchy. And sometimes you'll find individuals who will try to exert their dominance over you for whatever reason. Usually it's to feel safe. So if someone's trying to dominate you, it's usually about safety or some resource that they want. So you want to basically identify what it is that they really want. And sometimes this is as clean as they want a particular prescription or they want something to happen. Next frame, please. All right. This frame here shows some categories of aggression. Usually, most people will fall into that reactive aggression category. They're on the left of the screen. So if they're going to get angry, like 98% of the people who get angry or aggressive, it's because of a fear or a contest, something they want. They're very aroused. The initiation can be sudden. They either want to reduce threat or get something. The targets are easily switched. That means if they're screaming at you and I walk in the room, they'll scream at me. And when someone else walks in the room, they'll scream at them. They're obviously angry, wide-eyed, red-faced. They can be very loud, impulsive, highly aroused. That's the vast majority of what you see. About 2% of the population has what I call that proactive or predatory kind of aggression. They're calm. They want to manipulate the situation. They want to achieve a goal. There's usually a single target. They'll get you alone and demand something. And they can be very impassive, staring through you, smiling or smirking, very deliberate, methodical, and controlled. And you will feel really uncomfortable with that kind of person. So if you have any people like that in your practice, these are people you'd probably want to deal with somebody else there with you, and you'll feel better, and the situation will be safer. Again, that type of person is a very minimal, maybe 2% of our population. When we do get them in our hospital, we just have our staff go in with somebody else, and we manage deal with them pretty effectively. Next frame, please. Okay, this is basically what I've been talking about. The thing with the reactive aggression, they're responding to a threat, frustration, something they want. Basically try to remove the provoking stimulus. Sometimes it's an individual, there may be 3 of us there, and they target one person that's for some reason they find really threatening, and will ask that person to leave the room or have someone else talk with them, and that makes a difference. Right. And again, that proactive aggression, that predatory type is planned, single target, and generally in hospital settings, it doesn't usually involve a physical attack. It's more verbal. Okay. Okay. One thing that affects people's behaviors is this underlying death anxiety that we all have. And to learn more about this, you can look up Solomon, Sheldon Solomon on YouTube. He's got great lectures on the effect of being reminded of one's mortality. And what we see with this is when someone's reminded of their mortality, whether it's we're afraid of the patient, they're afraid of us, or some other situation, they can become particularly hostile, especially to someone they categorize as different. And different can be as simple as male, female, light, dark, professional, non-professional, anything like that. And the behaviors can become very, very irrational. And also population behaviors. When COVID came to the country, my mentor and I, in the end of 2019, we were basically discussing when is the civil unrest going to happen in Albany. I predicted first week of June. She predicted the last week of May, and she was correct. It was predictable because of this death anxiety. So that's at the bottom of pretty much a lot of aggressive behavior. So keep that in mind. Now, having a conversation about this isn't going to help them feel better, but there is something we can do. Next frame, please. Okay. This frame here basically, it gets to the point. If you can help somebody realize that they're a valued person in a meaningful world, this will reduce their reactivity. They won't go from really aggressive to dead calm, but it will help. And how do you do this? If you maintain your composure, regulate yourself, and genuinely ask that person and say, I see that you're really upset. Help me understand. That's telling them that they are a valued person. And then help them understand the situation, make some sense out of it. That will make a big difference. So you spend time with them. I see you're upset. I've got 10 minutes to help me understand what it is that you need. And then you can help them understand what's going on. That makes a big difference. So help people realize they're a valued person in a meaningful world, and that meaningful world doesn't mean the meaning of life. The present issues will go a long way to helping people feel safer, and this allays to some degree that out of control death anxiety without them even realizing it. This really works pretty well. Next frame, please. All right, risk factors for violence. All right, the top one is clear threats of violence. When they say they want to beat you up, believe them, always. Space in between you and them is best. If they have a previous history of violence and conflict, that means they've used it before because it works, and they have problems regulating themselves. So that's a predictor. Now, some people are under the influence of drugs, either intoxication or withdrawal. So that's a problem. And watch out for that. When people have taken way too many drugs, like they may have taken all of their ADHD medication at once, that's called excited delirium. Those people are dangerous. That's when you call EMS. And some people on steroids, like prednisone and things like that, they will actually get a little bit psychotic and can get aggressive. So one of the things I do when I see a patient and they have a very sudden change in mental status and they're aggressive, I check to see if they're on steroids because that can sometimes trigger aggressive behaviors too, even if they've been on steroids for years. It's a very interesting phenomenon. So check for steroid psychosis. These other ones you see below the highlighted part of the screen, these add to the potential for violence. Unrelenting depression, they're not thinking right, with anger, high agitation, mood swings, paranoia, homicidal, suicidal thoughts, substance abuse, past and or present. They're trying to medicate themselves to get that warm, soft hug they never got when they were little. obsessions and strong feelings of anger, humiliation, and injustice. If someone is saying things to you like you're disrespect, I'm feeling disrespected, and it's a theme, you can bet that they've had a lifetime of being disrespected. And of course, if anybody has weapons training, formal or informal, on top of these other things, they can be very dangerous. But again, definitely pay attention to the top two for sure. Next frame, please. All right, you want to establish a hierarchy of danger, which you actually are built to do already. But just pay attention. It starts out low, language that is intended to violate, demean, or degrade. When somebody is basically devaluing you, that's the first clue. When they devalue you and they start describing you as something disgusting, you know, POS or whatever, that's the next level of verbal assault. And the top level is when they consider you an evil person and tell you that you're evil. That's the highest level. And when you deal with like people with psychosis, if they think like you're the devil, they could get very aggressive. And people who are neurotypical may also get to that level where they think you're an evil person. So listen for that. Again, going from a devaluing statement to describing you as something disgusting through you're an evil person. That's the highest level of verbal threat. Obviously, people shouting are losing control, and the more activated a person is, the front part of their brain that mutes down the aggressive limbic system is kind of turning off. So the louder they get, the more the front part of their brain is turning off, the less they can think. And then we start getting into physical behaviors, pacing, stomping, all those posturing things. Males do it more than females. When they start attacking objects, punching walls, throwing objects is more increased. Trying to dominate you by standing too close is a higher level. And of course, brandishing an object or weapon in a menacing way, you need to go to safety. And you know, people throw cell phones and all that stuff. That's the highest level. Just get space, call for help. So be aware of the hierarchy, and we do want to intervene with words at the lowest level. Very rarely do people go from dead calm to attack mode. I've only seen it 3 times in my clinical experience since 1980, and there's usually a progression that you can pay attention to. Next, please. All right. When we are feeling completely threatened, we do one of 3 things. We avoid the threat by trying to get away from it. We basically leave the scene. We try to drive the threat away by being very obnoxious until they go away, or we get physical and try to destroy the threat. Remember that when people are being aggressive at you, there's probably an anxiety, a fear, or a terror that's underneath that. So we're feeling threatened and we're feeling afraid, but so is that person being aggressive, and they're viewing us as a threat, and they want to neutralize us or get us out of the scene. Next, please. All right. Now, here's where the attachment theory part comes in. We tend to model our interactions with other humans in the bulk of our lives based on what we had, especially during the first 3 years. And we don't have to have a perfect upbringing, but we have to have a good enough upbringing with whoever does the role of, say, mother and father, our primary caregivers. So if that's good enough, we tend to relate to other people, relationship partners, work people, people we meet in public, more often reasonably. But if we've had a tragic and unfortunate upbringing, then we may not have developed the capacity to have a good attachment and a good relationship and a good, basically, sense of regulation, emotional regulation later on in life. And if you look at people who are really, really violent, you'll often dig down and find that they had a tragic childhood. Next frame, please. All right. The infant, and essentially all of us humans, need to be seen to survive. So being seen, heard, and understood and validated tends to lead to a sense of safety. So that's helping someone realize they're a valued person in a meaningful world is key. Now, validated does not mean that you agree with what they're trying to get from you. It's that you understand that they're having distress and you want to get to some kind of solution. In order to help the other person, we must be able to self-regulate emotionally to co-regulate that other person. We are built this way. When you're a baby and you're upset and you're crying, somebody picks you up and helps you feel better. That adult is regulated and they co-regulate you. And we do this to this very day with people around us. Friend is not feeling well, you can read their body language and face that they're upset, and you say, "It looks like you're upset. How can I help?" You're co-regulating that person, and you do it with body language, facial expressions, what you say, and how you say it. Again, great. Okay, next frame, please. All right. Now we create mental models. So we create the mental model of everything in our lives, and we put this mental model in like a bullet point image in our head. So one mental model is what exactly is the caregiver. So if our mental model of our caregiver, let's say someone like our mom, is safe and reasonably responsible, then when we are a dependent adult person, say in a healthcare setting, and you, the nurse, or you, the other clinician, go in there, they will put a mental model on you that you're probably safe and you're probably going to be reliable in helping them out. But if their initial mental model of caregiver is unreliable, doesn't meet my needs, or is completely dangerous, that's going to creep out when they're dependent on you, the caregiver, and you're going to get these really strange reactions more in the hostile end of the spectrum, because they're projecting that mental model that all caregivers are kind of dangerous or unreliable. And we make mental models for everything. That's how we navigate the world. Okay, next. All right. The explicit memory is the memory where we can actually remember what happened. Most of the mental models we get from that implicit memory stage, we don't remember making these models. But once we can have a memory as our brain develops, we could actually recall what happened. And in that case, we can tell a story about it that we're a part of. And when people can tell you what happened to them when, yesterday or when they were little, that's something they can work with. But if things have happened to them before that time period, in that implicit memory stage, they're not going to recall any story, but they're going to get reactive all the same. All right, this graphic kind of lays it out. You see on the upper left-hand corner there, you got this mom and this baby, lots of eye contact, lots of emotional contact, a lot of that, like we call it right brain connection. So it's a good enough connection. And that baby, the boy there, is making a mental model of his mom. And then when he's an adult, he's projecting part of that mental model on his relationship partner and realizes that chances are my relationship partner is going to be, good enough. Now, on the lower left-hand corner, we have a not good enough situation, and it may be no fault of that person who's the mom there. She may have had a tragic thing happen. She may be ill. People she care about may have died, so she's not making that emotional connection with the baby, and that baby is not getting its emotional needs met, and it's developing a mental model that other people are not going to meet emotional needs, and then they wind up in situations to replicate that, and then they start reacting that way to people, even those who can be there present for them. Okay, this quick graphic just shows you the good enough attachment cycle with babies. It works the same way with adults. You come home from a rough day at work. You protest not by crying, but by showing body language, and your relationship partner or your person at home reads your body language and says to you, "Wow, it looks like you had a rough day. Let's talk about it. Let me get you some tea." And then you have an interaction, and then that person co-regulates you, and then you feel better, and then life goes on. Next frame, please. Now, if you've developed that mental model of a not so good attachment, you may come home from work and look a little bit upset, and the person who's home there does not respond to you. They're busy watching television. You start dropping your bag on the floor to let them know you're there, and then they start getting upset at you because you're interfering with their television watching. And then you get either upset and get angry at them, or you get apathetic and say, oh, well, this is life. And then you go off and get a glass of wine or something, and then calm yourself down. There's no connection there, and that other person does not regulate you. All right, so if you develop these deficits with that regulatory emotional thing when you're really, really little, it does affect even your cognitive development, and then you'll grow up and you may have problems with regulation, learning, behavioral things like that. So physical, sexual, emotional, neglect traumas when you're really, really little, especially birth to age 3, have far-reaching effects in adulthood, and you'll see it with your people who cannot regulate well at all. Next, please. All right, so do remember that these behaviors, these dysregulated behaviors that you see from these folks, they were once adaptive in childhood to get needs met. They served a purpose, but it no longer works anymore. So when they were little and they had to throw a tantrum just to be seen and heard and validated and to get some cornflakes, now they're 30 years old, they're still using that, and it doesn't get them what they want anymore. But they're built that way, they're wired that way, and they have to learn a new way. So the developmental environment has a predictive effect for violence potential. So when you find someone who's been passed around through 25 foster homes between birth and age 12, chances are they're not going to be able to regulate well due to the environment that they had to grow up in. And do remember that stressors and behaviors that they've had over the past 2 or 3 days can be a little bit predictive for what might happen today. Next. All right. Some people just haven't learned the appropriate social context for aggressive behaviors. Okay. They come from a violent world, and I've worked overseas in cultures that were very, very violent. They had to be that way to survive. And then when they were in Binghamton, New York as a refugee, you can't use those anymore because we have different contexts. Like, so in Binghamton, New York, when somebody insults you, you can't stab them. But overseas, in the rough place, you may have to do that to survive. So these folks with that mental model, that's not good enough. They may have a subconscious assumption of danger that all caregivers, which they also look at as authority figures, are dangerous. Next frame, please. Okay, we have that limbic system, that threat response system deep in our brain. We use it to go after things that give us pleasure and also to avoid things that are painful or scary or dangerous. So when we approach things, it's for need fulfillment, and we avoid noxious or dangerous stimuli, pain, and danger. That's safety seeking. So your people who are becoming aggressive, you'll see probably a combination of that. They want something to get a need fulfilled. They also want safety. So you see a combination of these 2 primal drives. Next, please. All right. So when you're looking at someone in front of you and they have extreme need fulfillment behaviors, they may be emotionally demanding, whiny, interrupting, dramatic, poor interpersonal boundaries. They may lie and do other manipulations. Okay. Now, some people lie and some people confabulate. You don't have to have dementia to confabulate. If you have a bad trauma history, you may have a tendency to confabulate and read a situation with a lot of fiction in it. And you've all met people who said that you did something or didn't do something, and they swear to it, and it's a confabulation, and they believe it. That's different than lying. Lying, they know they're doing it. So do know that some people who are neurotypical confabulate, and can you tell it apart from lying? Probably not. People also have these physical nurturance needs. You may see them, they want too much physical contact, inappropriately sexualized behavior that's too friendly, inpatient side, you see hoarding or stealing food, clothing, objects. Drug use, people who do recreational drugs, generally speaking, are trying to get that warm, soft hug that they did not get when they were children. And that's what they're doing. So when we get our patients in hospitals and we take away all the drugs, they don't have a way to get that physical nurturance, and they become very distressed. Right. Extreme safety seeking behaviors. Okay, they're feeling threatened. They can get aggressive, irritable, hyperactive, or they may shut down completely like a statue, get constricted emotions or avoid you, or become very hyper vigilant to the environment, or they may appease and accommodate you. Oh, you're the nicest, most helpful person ever. You're so wonderful. You're great. You're the best. That kind of behavior. That may be a over the top safety seeking behavior. Watch out for those. Next, please. All right. There are many, many, many tactics of manipulation and control. You all know them. Anger is a very common one. I just want to talk about guilt and shame, particularly here. These other ones you can read. Guilt and shame are very similar. They're like salt and sugar. They look a lot alike, but they taste different. Guilt is when somebody tries to manipulate you because you're a conscientious person. So if you forgot to do something and they say to you, you know, you didn't get my form signed and you said it was going to be ready today, you feel guilty, okay? And they're trying to manipulate you to get it done like now. Now, you're not going to be thinking about that at 3 o'clock the next morning. Oh, gosh, I forgot to get that paper signed. That's guilt. Once you solve the problem, fulfill the need or whatever, the guilt goes away. Shame is different, and we all have a shame trigger, and they play on a person's sense of inadequacy. So you've got somebody implying or overtly telling you that you don't know what you're doing, you're worthless. Did you ever go to school? Get me someone else in here who knows what the hell they're doing. They're shaming you. So you realize that one reason they're shaming you is that they probably had a lot of shame in their life, and they're trying to make you feel shame. So when someone is shaming you, just assume that they have a lot of shame in their life, and then do what you can to help them again feel to be a valued person in a meaningful world by sorting through the situation. These other ones, we've all experienced them. People are attacking you verbally and then putting in complaints to your boss because they said you were obnoxious when actually they were obnoxious. Intimidation, you know, my brother's a lawyer and that kind of stuff. That's another manipulation. Next, please. Right. All these others, you'll see, and you've experienced them. Again, that confabulation lays right next to lying. And those who confabulate actually believe that they're transmitting truthful memories. And so that's the difference. These others are quite plain to understand, and you pretty much have experienced them all. Next, please. All right. You'll see some of these other things. Diversion or distraction is a big one. They will wind up basically going after, we call it the red herring. They'll argue about something you said or did yesterday, as opposed to what they're doing today that's causing a problem. You know, they forgot to bring in their particular card that they need to get this thing accomplished, and then they're going off about what you didn't do the last time they were there. Get back on target. Okay. All right. Interventions. The key thing is your emotional self-regulation. And if this is the only thing that you take away from this lecture, then that's a really good thing. And I've tied it with this meme called Take a Minute, because it really only takes a minute to self-regulate. Begin the self-regulation process. Okay. So self-regulation is identifying, understanding, and using your body sensations, you know, dry mouth, sweaty palms, feel like I need to run, and emotions, right? Happy, sad, angry, disgust, all that kind of thing. Tie them together and then understand them and manage them. So you need to understand, manage, and cope with your own emotional, those are the words, angry, sad, happy, whatever, physical reactions. Emotions that we call emotions and behavior come from a physical sensation first that happens when we assess the environment with our five senses, and then the emotion part, the words, they come next, and then we act a behavior. So you have to be able to regulate yourself to manage that other person for a safer outcome. We have situations, say in the hospital, where I have a 14-year-old going ballistic, having an emotional meltdown, and then everybody in the room regresses to back to when they were 14 years old, and one person starts channeling their mother. They're not present, they're not regulating well, and then everybody triggers each other. We don't want to do that. Okay, it's a conscious process that we do, and what we want to pay attention to whenever we're about to engage in a situation, especially one that has a potential for a dysregulated person. That person's coming in and they tend to get really verbally dysregulated. You want to pay attention to your body sensations first. That's called interoception. You'll feel your sensations first to become aware of them. You'll name the emotions in your head. You'll have an urge to act or react. Act means you're choosing. You'll do your self-regulation breathing, as long as you're not having a conversation, which activates the parasympathetic side of your autonomic nervous system, which means it slows down your heart rate and the production of your stress hormones. You want to visualize what you want to have happen with that interaction, and then you're going to act, and then keep updating based on what's happening, and then you get to hopefully your final outcome that will be more positive. Interoceptive awareness is your ability to identify, access, understand, and respond appropriately to the patterns of the sensations in your body. This skill provides a really distinct advantage when you're dealing with all these challenges, especially in the social arena. As an aside, those who have high social awareness are also less likely to hurt themselves, as in suicide. And we find that it's a generally good self-regulation skill. Is everybody hearing me? Okay.
Yes, we're good. Thank you.
Okay, good. Okay, so there are different ways to do to read yourself. I do a global thing. I just sense like what is my body feeling now, and then dry mouth, sweaty palms, my stomach is tight. Some people go from top to bottom. My scalp is itchy. I had one person I work with says his ears tingle and such like that. So whichever way you want to do it, globally or top to bottom, pay attention to what your body's feeling. Emotional awareness, you have to be able to make sense of your own emotions and also the emotions of others. So you basically have to pay attention to reading that other person, especially their face. Okay, this word wheel is a common word wheel. You can pull a number of these off the internet. Really, if you just pay attention in that situation with your dysregulated person to that center part of the wheel, fear, anger, disgust, and sadness to a degree, those are the ones you might need to identify in your head. We often get startled, so surprise is the one that usually kicks them off. And we can have more than one emotion at the same time, so we can have fear and anger at the same time. So keep that in mind. Now that person is going through their emotions too, but they can't put them into words. So far, we've gotten the interoceptive awareness, and we're paying attention to our body sensation in facing that angry person, and we've named the emotion in our head. Next frame, please. Okay. Now, I've had to come back to teaching how to read faces. This is something I used to have to do in the early 1990s when the health department down in Broome County realized that little children were losing their age-appropriate skills at reading faces. So what I have to do now in my other classes is I pull up faces with the basic emotions, and then I say, from the wheel of emotions, name the expression on the face of the little baby. And then I find that, especially with people under a certain age, they have problems naming the emotion based on the face. So we have to practice that. And also the theory of mind, what's going on in the mind of that person. I have to prompt them to think about what would it be like if you were that person, what might you feel, what might you think. So this seems to be an ever-growing problem in our society that we have to practice. All right, how are we going to emotionally regulate? The controlled breathing is the way to do it. There's lots of research on this, and it will shift you from that stress mode to the rest mode, decrease your heart rate and blood pressure, improve your mood, and things like that. I like to use the 4x6 technique. So I say inhale, 2, 3, 4, exhale, 2, 3, 4, 5, 6, and continue that rhythm. And after about a minute, you'll begin to feel better. Obviously, you cannot be doing this when you're talking to somebody, but if you have to go talk to that person in the next 5 minutes, or you're the person standing next to the person who's getting angry and your colleague is talking to them, you can do the slow, deep breathing until it's time for you to talk, and you will be in a better state of mind. So you have to realize that you're anxious, and then do the interoceptive awareness, name the emotion in your head, and do the slow, deep breathing. And then visualize what you want to happen next, and essentially what might you want to say, what you may have to do if that person is tending towards physical aggression. Basically situational awareness. Visualize what you want to have happen next. And you can use this for basically predictive purposes in any kind of scary situation. Once I was an ER nurse in the 80s, and I was concerned that what would I do if a patient took the top of an IV pole and tried to hit us with it? And I did a quick planning. I would, leave the room if he came after me, or if he got in the workstation, maybe I would grab the pole, what have you. I thought all these different options and put it away in my memory. And then 6 years ago, I got a page. We've got somebody trying to hit his nurse with an IV pole in MICU. Can you talk with him? And I already had the plan in my head that I applied to it. So situations that you find really scary that you walk into in your clinical day, just spend a few minutes doing a thought experiment. What would I do if a person said this or did that? How would I keep myself safe? What would I watch out for? You'll have a plan in your head, and you'll be able to pull it up even 5 years from now if you need to. So do that thought experiment for things that you find threatening. Next frame, please. Okay, self-regulation exercise. We'll just do a quick one. I want you to imagine a mildly activating situation you've had with an encounter, not over the top, but one where you felt a little uneasy. Put that picture in your head, okay? Now I want you to recall that moment, that interaction, and recall what sensations your body was having back then, dry mouth, sweaty palms, whatever. Chances are bringing back the memory can actually bring back the sensation. Then I want you to recall the emotions that you were having at that time. You may have been frustrated, angry, scared, or whatever. Okay. Now I want you to take a deep breath in, 2, 3, 4, and exhale, 2, 3, 4, 5, 6. Inhale, 2, 3, 4. Exhale, 2, 3, 4, 5, 6. And continue. You don't have to count. Once you have the rhythm down, that's the process. Now, one way you can get good at this is to create yourself an emotional logbook. You can buy any kind of logbook. On our hospital, we use a small one that I pass out to people. So when you had an interaction that was activating, scary, upsetting, whatever, when it's all over, maybe later on that day or when you're home, you take one page, and at the top you write a sentence or two to remember what happened. Patient at the clinic screamed at me, and then bullet point the sensations that you had in your body, and then bullet point the emotions you had from the center of the wheel of emotions. And then after that, you can put a comment on either what this reminds you of your past. I know some people get very upset when patients scream at them because their parents used to scream at them, and then that may be a trigger for them. So at the end of that logbook entry, they would write, reminds me of when my parents used to scream at me, or reminds me of another patient that I had last year, and then tie that in with with the present, and you just do 1 page per entry. If you do this 3 times a day, even when there isn't anything threatening going on, after about 4 weeks, your reactivity is going to drop, because this practice creates new connections in your brain that will make you less reactive. The Army does a version of this. The school system in Australia does a version of this, and it works really good. And there's a logbook right there. And again, a page per entry. And then at the end of your week, just read through it once. And by the time you've filled out one of these books, they're like 48 pages, you will have the process down. And we get whole units to do this in our hospital, and it really makes a difference. Really makes a difference. So consider maybe doing this in your practice, the emotional logbook process. And you keep that book for yourself. It's not what you share with people unless you have a therapist. So that solidifies the process. If you're seeing a coworker who happens to be stressed and there's no overt threat, you read their body language and they're feeling stressed, you can say, hey, let's take a minute and do that self-regulation drill. And then you do silently, side by side, the interoceptive awareness, and name the emotions in your head, and side by side do some slow deep breathing for a minute. And then you can look at your stressed colleague and say, okay, need any help with anything? You want to talk about something? Okay, great. Create this in your practice, and over a month, you'll find that people will get along better, and as a group, you'll be less reactive. And again, this is research based. So do take a minute and look out for each other, value each other. Okay, next frame, please.
Charles, we did have a comment that you're moving a little bit fast. I know folks
Okay.
have been asking for the slides, and we will have the slides available on the website. I posted the website and the video. I posted the website, but so I can't get people the slides now. There's not sort of a mechanism for me to do that. But if you could just maybe slow down just a little bit. Is that
okay? Thank you.
Would that help folks?
Yes, very much. Thank you.
Thanks.
Okay. So again, make that self-regulation your personal practice, and that take a minute with your colleague, a workplace culture thing, and you will see an improvement like over a month. And I've seen it happen on units in Albany Med, where everybody kind of got along better after several weeks because they were better regulated and they were looking out for each other. Next frame, please. Okay. Be very aware of how you say what you say, the tone of your voice, how fast you talk, all that stuff, how loud you talk, and pay attention to your body language signals and all that stuff, because that's essential for a good communication. We're generally not aware of how we come across, and we generally don't have the capacity to film each other in action, but we can help each other after the fact when we've had an interaction with a difficult person. We'll critique each other. How did we do? What do you think I can do better? Oh, I think maybe you could talk a little bit slower, or you were standing in a more aggressive stance. So use each other's observations to help yourself improve your communication technique, the verbal one and the nonverbal one better. Okay, next, please. All right, so a lot of these things we already know how to do. Tone of voice. Ventilation is when you're getting that other person to talk about what's upsetting them. This does not work with people who are manic because they just keep on going, but for the average person, it's a good thing to do. Distraction is after you've dealt with the problem at hand, sliding into a topic that is pleasing to the person, and then leaving the conversation on a good note. Reassurance is very simply reassurance that, once you make sure that they understand what's going on, we have everything taken care of here. All the wheels are in motion, so we're good. Okay. The one-on-one is what you get a lot of. And a one-on-one is when you are dealing with that individual. And when I do one-on-one situations, I always put in a time limit. I have 10 minutes to give my undivided attention with you before I have to go on to the next thing. If there's anything more we need to talk about, we can pick it up next time. So that way, when the end of the 10 minutes comes, you can say, okay, I'm sorry, but our time is up. Otherwise, they may monopolize you, and you won't have an easy way to end the conversation. So put in a time limit. And if you're dealing with anybody who you feel is threatening, you want to go in with another person. And there are many times where I've gone in with a clinician who had to tell the patient something that would get them angry, and I would be in there with them also. Modifying the expectations is the expectations of that person. Now, they may be expecting that if they scream at you, you're going to either run away or go into verbal attack mode, and instead you come across as that good attachment figure, calm, limit-setting person, and they will respond to that because you're not being reactive. And on a subconscious level, they're going to begin to mimic your calmness. So you're modifying their expectations. Whenever they scream, everybody either runs away or gets ugly on me, and this person isn't. This person's being calm. And then they will begin to mimic you as they metabolize out their stress hormones. Deflecting the insult is a really important technique. And essentially, you need to know what your triggers are, because we all know what one person can say to us in one sentence that will completely piss us off. You've got to know what your trigger is, and you have to have a pre-built statement to kind of to end that interaction in a positive way. So if somebody calls me a stupid, uneducated nurse, and that's assaulting my sense of self, then what I'm going to say is, yeah, people said that to me before, but this interaction is really about you and what you need. So help me understand what you need. So you really have to regulate yourself well. You need to know what your triggers are, some of which you'll learn from doing that emotional logbook if you don't know already, and have your stock statement. Oh, yes, people call me that. One of my colleagues was my psych nurse colleagues gained a few pounds over the decades of working, and she would go in to deal with a person, and as soon as she'd say, my name is, that patient would say, you're a fat whatever, and then she would answer with, yeah, I could use to lose a few pounds, but I'm really here to understand what you need so I can help you. So help me understand what you need. And that takes the winds out of their sails almost immediately, most of the time. But you need to know your triggers, you need to regulate well, and you need to have your pre-built script so you're not taken by surprise. Clarifying the emotional status is essentially empathy. I see you're upset. And we all do that. Just make it a practice. I see you're upset. Use your words with the emotions. I see you're upset. If I were in a similar situation waiting all day, I would be upset too. Upset also. Let's see what we can do to get things moving along. Okay. Next frame, please. All right, next. Okay, good. These things we tend to do naturally. Sometimes you just need to not say anything. I had an incident last week with a dysregulated teen patient, and everybody was talking. So I basically said to the room full of everyone, let's not talk. Let's be silent. Let's stop talking. And then everybody stopped talking, and the screaming teenager settled down within about 3 minutes. So sometimes silence is very appropriate. Use your body language and your nods to know that, so they know you're paying attention. Selectively focus on the content that you need to process. So when they're basically becoming a little obnoxious, pass over that. Use your eye contact appropriately. Don't stare, and don't just look away, because staring at them is aggressive, and looking away can be read as you are being the prey kind of person. You're being threatened by them. So use maybe 60% looking at the eyes and the rest looking elsewhere. Proximity is how close you sit or stand to them. The angrier a person is, the further away you talk to them. And I've talked to many people from halfway across the room. Generally avoid touch with any angry person. Do not touch them at all, okay? Sometimes they will act out when there is a huge audience. So if you either ask them to a quiet area or remove the audience, that can help a lot. And if there's too much stimulation, as in like too many people talking at once, you can control that. Again, controlling the environment can shape the behavior. So be aware of the environment that you can control. Timeout essentially is when you basically have to say, okay, this behavior is really inappropriate, so I'm going to give you 15 minutes to kind of think about what you want to say, and then we'll pick up the conversation again. Again, also be aware of your body language and posture. Redirection is going to a different activity, or even moving across the room. Oh, let's go talk over there in the corner. Believe it or not, that actually helps in helping people settle. And of course, you're going to model the behavior you want to see from that person, because that works off of a thing called mimicry. So you act calm and non-threatened, and then you're not coming across as a threatening individual. You're coming across as a safe individual. Next, please. All right, you want to build yourself a script that works for you, that you can pull up when you are startled, when somebody takes you by surprise. Always, always, always identify yourself with a name. It is really more difficult to hit a person with a name than somebody who is just an object, like a category, like a nurse or a clinician or a person who works there. So whenever you walk in and deal with a person, you use a name. So I walk in and I say, my name is Charles, and I'm here to help understand what you need. So I set up the emotional milieu from the beginning and identify myself as a person. So always identify yourself by a name, whatever name you want to use. Okay. And then you're going to build yourself a script. So one thing I say to people is, I'm sorry you feel that way. I'm sorry that you're really upset. And another thing I say to people is, help me understand what's going on from your side of the situation, so I can help. So build yourself a script. You can use some of the ones here, or create ones yourself, or look on the internet for scripting and adapt what works for you in your clinical situation with the kind of situations that you have. Build yourself a script, memorize it, which won't take long, and then it'll become automatic. Hello, my name is Charles. I'm here to help understand what's going on. I see you're really upset. I can tell it's hard for you. Let's cross the room and sit down, and then tell me what's going on. That is valuing a person, and then you're also understanding them, so you can help them understand what's going on. You're helping them find that meaning. You're seeing, hearing, and validating them, and then getting to some kind of solution, just like hopefully your good caregivers did for you when you were little, and how you work and deal with the people you care about in your personal life. This is basic social stuff with a scary person who is not your relative, in a professional situation. The same thing works for them. Okay, next, please. Okay, when you set limits, it's always good to set limits exactly the same way, in concrete terms, in short sentences, because that person is angry, and they're not going to hear complex things. Okay, so basically, a common model that you can find off the internet and people are taught is, first thing is to explain which behavior is inappropriate. Concrete, short sentence, why it's inappropriate, give the person reasonable choices, and allow an appropriate amount of time for them to make a choice, and always enforce the limits, because if you do not, then they're never going to listen to you again. So you have a person who comes in the waiting area and they start yelling, and you talk to them from a safe distance, say that they already know who you are. Please stop yelling. Okay, that's the inappropriate behavior. It's upsetting everybody, and it's going to cause the situation to take longer to get fixed. Give them reasonable choices. I would like you to take a seat over there, and then or you can leave and come back another time. Whatever you want to do, an appropriate amount of time. It only takes a minute to cross the room and sit down. So I couch these things all in one term. I'd like you to make a good choice and go take a seat over there and think about what you want to say for 5 minutes, and then we'll talk. And if you cannot, if you continue to scream, we're going to ask you to leave. So and then you must have a way to enforce the limit. So don't set limits on people that you can't enforce, because that's not going to do anything. In a hospital situation, it's really easy to see when you have, say, a person on a suicide set who's trying to escape, and we can't let them go because of the way we have to keep them safe, and there's the mental health law, and we corner them by the elevator. We'll say to them, you cannot leave because you did an impulsive act of self-harm, and we have to keep you safe. We would like you to go back to your room under your voluntarily, or we will help you back there. And essentially, I would like you to, I'm going to give you 1 minute to make a good choice to go back to your room, or we will help you back there. And then when that minute's up, we say, okay, minute's up. I'll ask you one more time to go back to your room after, go back to your room, or we will help you back there. And then if they don't make a move to go back to the room, we've already predicted that there's only 5 things that can happen, such as they'll turn and go back to their room, they'll curse at us and go back to their room, they'll try to argue why we should let them go, they'll stand there like a statue and we'll bring them back to their room, they'll try to escape past us, or they may get violent. Those are the only 6 things that can happen, and we're prepared for all of them because we've done that prediction thing. What is most likely to happen? And we accommodate these potentials as best we can. And you can apply this model for pretty much any kind of clinical situation fairly successfully. And again, always enforce your limits. Okay, so here's an example. Hard limit set. Now remember, when you do a hard limit set, you're going to get pushback. Just like when you tell a child no, you're going to get pushback. A dysregulated person is not working as an adult. They're working as someone who doesn't regulate well, like a child temporarily. So when they're yelling at you, you say, you can't be yelling at me. This is not helping me understand what you need. Please talk in a lower voice, or you can choose to talk another day. I'll give you 5 minutes to make a good choice and decide what you want to tell me in a calm voice, or we'll have to end this conversation for today. And then after 5 minutes, ask them to continue the conversation. And if they continue to yell, then you end the interaction. So that's how the model looks in a person yelling at you kind of situation. Do know that when somebody is activated, they're running lots of adrenaline and those stress hormones, and they're feeling triggered. So once the trigger is over, it takes a number of minutes for that stuff to metabolize out, because that's making the body feel threat. So a lot of times we deal with patients, we give them 15 minutes, because that's usually enough time to metabolize out that adrenaline, and to a point where they're not feeling like they're trembling, and the front part of their brain is actually turned back on, and they can reason better. Okay, next, please. All right. The general framework when I'm approaching someone who may be upset, as I go through these steps in my head, what am I feeling now? That's that interoceptive and emotional awareness, and the slow, deep breathing. I do that as I'm approaching, okay, in the hospital. What does this person feel, need, or want? What is it like to be that person? This is that theory of mind thing. What would I feel like if I were that person? And what may that person be feeling? What might they want? How is the environment affecting the person? Maybe it's too hot, too cold. There's a crowd of people around them. They've been waiting all day. They're in a lot of pain. It's too noisy, whatever. Look at the environment, because you have some control of the external environment also to some degree, even if it's how close or far away from that person I stand, or maybe we should move to a different room or the other side of the room, or maybe we should sit. If you're ever dealing with somebody who's angry and you're sitting, if they stand up, you stand up, okay? If they sit down, you can sit down. So be on the same level with an angry person and always have the door to your back. What is the cognitive capacity of this person? Basically, how well can they think right now? Now, obviously, if they have dementia, they have an impaired ability to think. But if they're angry, they have an impaired ability to think. And when they're screaming, they have a significantly impaired capacity to think. And when they've shut down like a statue and won't talk, they also cannot think very well. So we have to de-escalate them down into that middle range of being not maybe fully calm, but calmer. And then they can hear us, and then they can express themselves appropriately. What I see over and over again is people trying to reason with angry, irrational people. That person cannot process what you're saying. You have to use your body language, your tone of voice, and all that. Maybe give them some time, change the environment to get them to kind of wind down to a calmer situation, and then begin to have that conversation with them. What is the problem we are dealing with? So many times I walk into situations and the staff can't even tell me what the issue is with the patient. So what does the patient want? We're not sure. Okay. You want to know as best you can what's the situation that we're dealing with. And generally speaking, it can fall into two categories. They're not feeling safe, or they're not getting a need met. Okay. Those are the two gross categories. And then you get down to the specifics. He wants his prescription, or she wants to leave, or she's in a lot of pain and wants medication, or a person wants this form signed so they can bring it back to their job so they can go back to work. Okay. What's the problem we're dealing with? Now, safety from our perspective as clinicians, we always keep safety of the person and ourselves high on the list, always. What do we want to make happen? We want the person to be calmer. We want to at least get moving towards solving the problem that's making that person upset, if it's something we can do something about. We definitely want to keep everybody safe. How do I best respond? That's the art of using these techniques plus your innate capacity for communicating that you all have. So it's assessing the threat, self-regulating, co-regulating, okay, limit setting if you need to, and then in manipulating that environment for the safest outcome and the most advantageous outcome to get where you want to be, that goal. Okay, that's the process. Next frame, please. All right, so you always have to self-regulate to co-regulate. Okay, and if you're having an interaction with people and the person next to you is a staff person and they're getting angry and their voice tone is popping up and they're starting to do this posturing, you'll have to ask them to leave and say, I'll continue this conversation. You can go now. Because what happens is somebody starts triggering the patient, or maybe that patient is viewing your colleague as a threat because that person reminds them of their father or their uncle or the kid who beat them up in the 4th grade. And your colleague is doing the best they can, completely appropriately, trying to talk that person. But that person's way they look is setting that patient off. That's when you say, I'll take over now. You can, go back to your office, and I'll talk to this person. And because sometimes it's an old thing that's triggering that patient and it's got nothing to do with what you're doing right or wrong. Now, what they say at you isn't personal unless you make it so. So don't make the interaction personal. Really hard to do. So when somebody completely berates me in front of a room full of my peers and calls me all kinds of stuff, my body will react, but I don't know this person from anybody, and they're just saying stuff at them because they're angry and scared. It's not personal unless I make it so. So I always keep in mind that that person who's angry is a person in need who's probably really afraid and is using anger and rage to get safe from their perspective. So if you understand the why of the behaviors, even generally speaking, you can loosely predict the behavioral trajectories. You can't predict he's going to throw a chair across the room in 5 minutes, but especially with people who you have history with and you understand where they come from to some degree, you can predict behavioral trajectories and accommodate these trajectories in an appropriate way, again, by situational awareness, self-regulation, co-regulation, manipulating the environment, and helping that person be seen, heard, and validated, and help them realize that they're a valued person in a meaningful world by helping them understand what's going on. So that's pretty much the wrap up. Doing the self-work with the self-regulation and the emotional logbook goes a long way to helping the other person regulate and yourself. Having a script for when an angry person startles you is a really good thing. And I've also forwarded, I call it a communication plan. It's a common kind of a crisis prevention plan that you'll see in different hospitals and the Office of Mental Health. You can ask those questions in your head of that person, and those of you who don't know what I'm talking about, you'll have access to this document. It's essentially asking a person, what gets them angry, what's a trigger, how do you self-regulate, how am I going to know that you're getting angry, what really works, who do you want to talk to, who don't you want to talk to, how can we accommodate your needs. It's basically a communication tool. It's not generally part of a chart. And again, some places will actually write down on that and rubber band it to the front of the chart and shred it when that patient leaves the hospital. The rest of us actually just keep it in our head and then recite it to our next coworker when they come on shift. This person starts to twitch their hand when they're getting activated, and they like to listen to music to calm down, or they want a calm conversation about how they're feeling for 10 minutes alone. That's what works for them, or whatever. And we pass that information along. So you can use that communication tool as a plan to assess that person and have information that you can use to predict their behaviors to a degree, and also share that information with others. Also, you can more operationalize it as a reporting tool that you can actually fill out and write down, and then pass that along from person to person, shift to shift, or whatever. And whether you use it as just a tool that you shred afterwards, or depending upon your institutional rules, some people keep this, most places shred it, depends upon your institutional needs. And a lot of us, we just keep that in our head and we pass that information along to people who may not have met that patient yet verbally. Okay. Any questions at all?
You
So you
can
see this is built.
you can put your questions in the chat, or I suppose we could risk unmuting.
Yeah.
So we have folks saying, thank you, it's very helpful working in the field. Thank you, worth a follow-up.
Mm. Good, thank you.
Cynthia, what kind of follow-up are you thinking about?
Different kinds of follow-ups. We can actually, in a more open forum, discuss, say, boilerplate clinical situations. I go into this clinical environment with this person who does A, B, and C. I tried this, I tried that, that didn't work. Can you give us some guidance on how we might deal with that person in the future? That's one thing we can do. And I do that with groups.
Okay,
We
so
basically-
maybe we have an evaluation link in the chat, but we'll also be emailing one out to you. Maybe we can talk with Charles about seeing if there's a way to do some kind of follow-up. I just want to make sure. Would like more examples towards the end. The specifics helped. Understanding the terms and the process was helpful. So if we do some follow-up, maybe
yeah.
we can use that approach. Very
Right,
informative.
yes.
I've attended these trainings in the past and this offered a nice insight. A lot of great tips. So we're really hopeful that this adds to your toolkit as a care manager in the field. And we can talk to Charles if people think it would be helpful about doing some kind of follow-up. If in your evaluations, you can make sure you note that, that would be great. And like I said, the slides will be available on the website. When we send the evaluation, we'll also send the website if you missed it in the chat. So I think we're good. Anything else, Charles? Thank you so much.
Thank you all very much. It's been an honor and a privilege.